So if you look at healthcare in most developed world, it has depended on the architecture that is not currently working for the current outbreak. The developed world, for a good while, we all have taken for granted that diseases are vaccine preventable, supplies are on the shelf, water is flowing through the tap, and infection control measures are in place. And so that people relied on that heavily. With the wave of the spread of COVID-19 across the globe, it is a clear indication that there is a weakness in every healthcare delivery system, and we have to always keep that in the back of our minds and consider that in case of an emergency. The situation from the West is the opposite in low and middle income countries, where the systems have always been weak, and we look up to the developed world for assistance, especially during outbreaks. So we look up to them for human resources, financial resources, and material resources. Today, the whole world almost have an outbreak. And so as a low middle income country, we will not be able to depend wholly and solely looking up to the developed world for help. So with that, my first recommendation will be to mobilize and mobilization and coordination of domestic resources. That means human resources, financial resources, material resources. That will be key for the success of fighting the disease. During the Ebola outbreak, we had to implement Liberia a two-pronged approach, and that actually took place after our routine healthcare system collapsed, and we had to find a solution for that. So the IMS, the incident management system, was established, a multi-sectoral system with different pillars to respond to the outbreak. And then the routine healthcare services, the chief medical officer, then I was the chief medical officer, had to take the lead in reviving the routine healthcare services. The two systems functioned under a presidential advisory committee, and we reported to the president weekly on progress. Now, for the routine healthcare services, we had to organize a team of Liberians. So they were all Liberians. They were trained and empowered to go to each health facility. So they were like a SWAT team, and to go and reconfigure healthcare environments and to optimize conditions for patient care and healthcare workers' safety. To implement infection prevention and control for a highly infectious pathogen in health system, we apply rapid training, mentorship, and supply and environmental changes for infection prevention and control measures. So in Liberia, we had like 23 hospitals plus over 600 clinics. All the people were trained, not only nurses, physicians, but we also had to train people, the cleaners, hygienists, the security to monitor temperature, to be able to triage, those kind of things. So we had to train people to deploy. The most important thing, the most important part of this is that we plan and we implement it. So there's a need to plan for the response for the routine healthcare services during an outbreak and actually implement. Protecting health workers should be the number one priority for any minister of health during an outbreak. The infection of health care workers and deaths affects the morale of those who are on the front line. And then subsequently, it leads to, it affects the delivery of health services. it leads to the collapse of the health services, like we saw in Liberia. So infection prevention and control should be the bedrock for ensuring that health workers are kept safe while serving. Of course, PPE supply chains are the heart of a system that ensure healthcare workers' safety. During the Ebola outbreak in Liberia, we did not have enough PPEs to support health workers. So partners had to fly in PPEs for us. Today, that might be a little bit difficult, but the experience from the outbreak, we actually also reserved in stock for emergency personal protective equipment should in case we have an outbreak like we have now. Well, how long that will carry us, I do not know, but at least there was something to start off with. So it is good in time of peace, prepare for war. Community health workers are people who are really respected in their communities. They have been working with the community on routine care. And during the outbreak, they actually provide the leadership for community education and contact tracing, active case search to be able to support the healthcare delivery system. With that experience, for Liberia, we organized them formally. And so they form part of the routine healthcare services at the moment. So with the outbreak of COVID-19, we are still using them for active case search, contact tracing, and health promotion activities. Again, we should remember that the outbreak is highly infectious, and so community health workers will have to be protected. Now, in Liberia, at the moment, we have professional health workers. Once there's a suspected case, professional health workers go do the assessment. A test is done. Once the contact is test positive, that contact is taken out to a treatment unit. The close contacts are the ones that the community health workers monitor. And they even do that with some basic PPEs. Yeah, during the outbreak early in 2015, so the outbreak of Ebola was around, it started from 2014, it carried on to 2016. But late 2015, we developed what we call the investment plan for building a resilient healthcare delivery system. And in that plan, we had like 9 pillars. The first pillar was a fit for purpose health and motivated health workforce. We made that a pillar number 1 because during the Ebola outbreak, when health workers started getting infected, health workers were afraid, routine healthcare shut down, a lot of health workers died, close to 200 health workers died. We already did not have enough health workers before then. So that was our pillar number 1. The second pillar is to re-engineer health infrastructure. We realized that our health infrastructure was also not built to address infectious diseases when we have an outbreak. So we had to do some adjustments. So we had to build triages, permanent triages, knowing that there will be outbreaks on and off. And then we also built some isolation units that hospitals could isolate if there's a case, and those ones we build them regionally. And then whilst you are addressing the outbreak, you can also expand on the infrastructure based on the impact of the disease. We also, the third pillar, we consider epidemic preparedness, surveillance, and response. And that led us to establishing what we now call the National Public Health Institute that leads emergency preparedness and response. Since its establishment, we've had some other outbreaks, meningitis, for example. We were able to intervene quickly. Prior to that, we had some Ebola outbreak continuous from the Ebola phase. Health workers did not get infected. We were also able to put that under control quickly. That system is currently in place. And when I'm winding down, I will tell you how it is functioning. There's a little bit of challenge with that at the moment, but it is working. Then we also considered as the next pillar management capacity for medical supplies and diagnostics, so that we will be able to have supplies in stock for routine healthcare services and for emergencies. With this, we even have some forward bases that we pre-position things, should in case that there's an emergency across the country, things can be lifted from one end to another. So PPEs, for example, were already pre-positioned in forward bases that can be lifted quickly to counties when there's a need. There are some challenges there with that also though, because we do not have enough resources to actually stockpile drugs and supplies as we would like to do that. The next pillar is comprehensive information research and communication management. And that we also restructured our entire active surveillance, passive surveillance around that. We continue to do the weekly active surveillance and the monthly passive surveillance, and we provide this information widely, and that is in addition to the health promotion activities. The next pillar is sustainable community engagement. And we actually build on the experiences we had from the Ebola outbreak, especially building on the community health worker program. Prior to Ebola outbreak, we did not have a community health worker program. We had community health worker program that was very fragmented. We reorganized that more formally, revised all their training materials, their tools, and the policy and the policy and strategies. And so today we have a more formal community health worker program. They are supervised by health workers, professional health workers. They were already in the system addressing routine healthcare services. And then for the response, they also support some of the activities that I mentioned earlier. We also looked at leadership and governance capacity, and we also did some capacity building around that. And before I left the ministry, we were working on the last pillar, which is the efficient health financing system. To present, most of the public services are free to the end user. There are a lot of challenges with it being free, so we're considering health insurance and the like. Some policies were designed before we left and turned over to the current administration. Now, the question of whether the Liberia healthcare delivery system is resilient. For the healthcare system to be resilient is a process. It is not an event. Definitely, Liberia healthcare system is a little bit stronger than what it was during the Ebola outbreak. I have mentioned some emergencies that we had earlier, that we had interventions and we were able to put them under control. I believe if we did not have that system in place, EVD would have been worse than what it is in Liberia currently. But we also have some challenges with the system as it is currently. In Liberia and in our part of the world, once there's a change in leadership, a lot of things also change. So though we have the incident management, the National Public Health Institute, that should be working along with the Minister of Health to activate the incident management system at the national level and then throughout the counties. A lot of the technicians change along with the politicians. So we have a lot of people, new people in place at the incident management, at the National Public Health Institute, as well as the Ministry of Health. So from the onset, they had been struggling, the political influence, and that has impacted the way we responded to COVID-19. I think we would have responded better if the technicians who fought the Ebola and were trained during the process were still in place, if most of them were still in place. At the moment, a good bit of them have been changed, and so that is also affecting the response negatively.